Good evening, everyone. I'm Chris Morrow. I'm an emergency physician and previous rural family physician, and lucky to be here today in my role as the Executive Medical Director at UBC CPD's Division of Continuing Professional Development. I'm happy to welcome you to this webinar, Creating a Safe Space for Indigenous Patients in Primary Care. We're very fortunate to be joined by Kaitlin Frost and Dr. Carolyn van Schagen, who are here to share their journey with respect to this topic and to answer your questions. I'd like to acknowledge that UBC CPD's office, as well as the Dr. BC's workspace, is located on the unceded territory of the Coast Salish people, which includes the Musqueam, Squamish, and Tsleil-Waututh nations. I know we're all calling in from different areas today, and I'd like you or encourage you to reflect on the traditional owners and caretakers of the lands where you are currently situated. I'm an Irish immigrant and settler calling in today from the unceded and traditional territory of the Coast Salish peoples also, more specifically the Lekwungen speaking people, so the Esquimalt and Songhees nations, and also the Wasanic nations. Today, we're just so grateful and humbled to be joined by Dennis Leon, knowledge keeper and cultural advisor from Kaitlin First Nation. He will be opening our time together. Over to you, Dennis.
Can you hear me? Okay. Siam Osiaya, Siam Otis Wilmuk, Eta Squalawell Klaus Quetzlama, Saitumtin, Del Wilmuk Swi, Delito Qua Kaitlin, Kesta des Wilmuks de Elis, Wilmaquium, Equestani Alepta Kaitlin, Katesi Simiamu Softamuch. Good day, everybody. My given name is Zaytumtin. Come from Kaitlin First Nation. Also acknowledging my lineage in Staelis and Musqueam. Just gonna share a song with you guys and open up the meeting here and calling in those good vibes and those good energies. Hi, Chika. See ya. Hey ho, hey ho, hey ho, Yeah.
Chris, you are muted.
Thank you. Sorry, I keep forgetting about the mute button, everybody. We can all relate to that. Thank you, Dennis, for that beautiful opening. I'd like to also thank doctors of BC Indigenous Specific Anti-Racism and Cultural Safety Team with the support of the JCCs who have collaborated with UBC CPD to support the education and development of this webinar series. So some housekeeping things. This is a 90-minute webinar. We're going to have lots of opportunity for questions, and we'll be using Slido for that. You can access Slido by scanning the QR code that you see on screen now, or you can go to www.slido.com and enter the code safe space, all small letters, and that's safe space, all small letters. Or you can also use, there's a direct link in your email invitation to this webinar. We're going to try to get to all of your questions, but we may not have time. And some of you may know there's a mechanism that you can upvote questions. So if you like a question that you already see on the list and you want it answered, if you give it a thumbs up, it'll rise to the top of the questions. Also, today, if you do have technical difficulties, don't fear. We are also recording this webinar and you will receive a copy of this. And there will also be a link to any of the resources that we may mention this evening. At the end of the session, please remember to take a few moments to complete the attendance and evaluation forms. You can access these forms by way of the email you received for this session. And in order for participating physicians to obtain CPD credits, you need to complete the online attendance form. So please do that. So there's two main objectives for this evening. One is to identify actionable steps for creating a safe space for Indigenous patients in primary care. And the second is to reflect on personal practice delivery and what learning opportunities you may see through this learning. We're very fortunate to have Kaitlin Frost and Dr. Carolyn Van Schagen presenting tonight. They have no disclosures. And you can see the planning team there as well, which also has no disclosures. I'm very excited to hear this story tonight. This is an example of amazing work and some positive things to celebrate. We often talk about the deficits and problems with cultural safety and the work we need to do. And I find this story very inspiring and I'm excited to hear. So I'm going to turn it over to our speakers.
Thank you, Dr. Morrow and Sarah. I will just get my screen up for everybody. Okay. Okay. Good evening, everyone. Thank you, Dr. Morrow and Sarah, for this invitation to present a part of Langley's learning journey and work towards creating a safe space in primary care for Indigenous patients across the province. Thank you, Dennis, for opening us in a good way. And thank you to all of our guests and listeners for taking the time away from your family, your friends, your fitness schedules to be with us tonight. So I'd like to acknowledge and share gratitude that the work completed by the Langley Division is done on the traditional ancestral territories of the Kaitlin, Kaitlin, Matsqui, and Semiahmoo First Nations, and is through our continued learning and journey that we have learned that these lands are also home to many Inuit, Métis, and away from home Indigenous friends and families. My name is Kaitlin Frost. I am an uninvited guest on these lands. I am the granddaughter of Jim and Edie Frost, the daughter of Jamie Frost. We are of mixed European descent with a most recent Acadian lineage from Nova Scotia. I am a dog mom, a sister, an auntie to two wild and outgoing nephews, and a partner slash caregiver because every man needs a little bit of caregiving. I work, or at work, I am the manager of member and community engagement with a focus on building strong and meaningful communications and partnerships. Before diving in to the depths of how this work came about, I did not want to pass up the opportunity to express that being able to share and present in June, National Indigenous History Month, and so close to National Indigenous Peoples Day, is an honor and humbling request. I also want to share that I do not consider myself an expert in Indigenous care or cultural safety by any means, but I am on a learning journey with our physicians, and I'm just an expert on this project. So, getting a little bit into the nitty-gritty for the next 40 minutes, I hope to give you all an in-depth understanding of how this project was developed, the goals that kept us going, who was involved, and where we would get our support, and the Indigenous voices that guided the work, how we were able to engage patients and community members, our primary care providers and their commitment to learning, the lessons learned, and last but not least, how we as a division continue to grow and navigate our learning journey. So getting started. In early summer 2021, the division hosted Jody Jones, a traditional wellness coordinator with First Nations Health Authority, over a virtual knowledge sharing and education session focused on introducing cultural safety and cultural humility. Side note, we also had the pleasure of having Dennis opening us in a good way on that night as well. Jody introduced our members to Indigenous history, personal stories and experiences, cultural knowledge and resources, and the first steps to creating a safe space for Indigenous patients in primary care. And that was how to approach patients in a way that is comfortable and engaging. This session was just a stepping stone and a starting point to what would get our primary care providers underway on their learning journey. Following the presentation, members were asked to complete a questionnaire or poll, and from that, the results that we received were that 100% of our members in attendance, there was just over 110 guests that evening. They reported that they are all willing to commit to care that is culturally safe. And then 96 of those who were in attendance, or 96% of those in attendance, were willing to receive feedback from patients who identify as Indigenous. And it was these outstanding results and reception of the presentation that sparked the development and the ideas for this project. So out of the need for patients and primary care providers to feel safe in their medical and healthcare journeys, the project that I will be speaking about was focused on physician engagement and learning while developing cultural awareness and how to provide a culturally safe space for patients to self-identify, discuss care, receive care, and report happenings that were not culturally appropriate. Through the fall of 2021, we listened and continued to learn. It was important to work collaboratively with our local Indigenous communities and organizations, and not to reflect back as a consultative partnership. We visited other divisions that had already worked with Indigenous partners, and it was then that I first met Gracie, who is joining us this evening, and it was during this time that our Indigenous leadership team was created. So we put out an invitation to our community partners, our local First Nations, and local Indigenous societies, asking self-identifying Indigenous community members who were interested in working together and in sharing their experiences and the experiences of their community to help advocate and steer the direction of culturally safe care in Langley. It did not take long to get our contacts gathered for a good meal and good conversation. No agendas, just really listening with heart and open ears. And with that came the commitment of 8 to 12 community members, depended on the day and availability, and the 2 lead primary care providers, one of which was Dr. Carolyn van Schagen, who is also on the call with us tonight. And that was our focus group who led the rest of the project. In early 2022, we submitted our expression of interest with the team at Shared Care. I worked closely with our liaison and the evaluation team because there weren't many shared care projects of this nature that had been submitted previously. So from the start, we were aware that evaluation would be done differently, and the timelines were not necessarily going to be followed strictly, that we had to work with our Indigenous community the way they were able to work with us. So we proposed to support the development and facilitation of a community and platform where primary care providers can consider their roles in creating a safe space and to be open and curious to learn and to engage with our local Indigenous voices, in turn building trust, respect, and relationships. Our aim was to identify and implement a process to create secure and unbiased care for the Indigenous community in Langley while providing education, collaboration, and culturally safe space for healthcare needs, self-identification, and reporting of unjust treatment. Keeping our eyes and ears open and our mouths as quiet as can be, we listened and we learned. We took actionable items from both traumatic and uplifting stories, local experiences, and from the voice of our Indigenous leadership team. And it was from those discussions and actionable items that together the guiding goals were established. So those included providing Indigenous patients with a safe space to receive longitudinal primary care, to increase the awareness of culturally safe practices and Indigenous history, to increase knowledge of Indigenous specific resources, both locally and regionally, to support division members on their learning journey, to build stronger and trusting relationships with local Indigenous communities, and number 6, last but not least, to provide Indigenous peoples in Langley a voice and the opportunity to lead change as partners in care. So gratefully, with the support and direction of the leadership team, we were able to strengthen relationships with several community partners and our local First Nations. One being the Lower Fraser Valley Aboriginal Society. And they serve Indigenous peoples who are away from home, or urban Indigenous, and as well as those living on reserve. So they supported us through shared feedback from both their team members and their clients, and helped distribute event and communications collateral. Our partnership with the Lower Fraser Valley Aboriginal Society continues to build as we offer attachment to any of their clients without primary care providers. We are lucky or fortunate enough to have a number of physicians and nurse practitioners who make space in their panels when asked specifically for Indigenous attachment. And then we go about it in a good way with no extra forms or documents, just leading right into that meet and greet with the care providers. We also try to attach the patients as close to home as we can to avoid any transportation concerns. A quote from one of their team members is highlighted there in blue. Our partnership with the division provides an opportunity to make sure all our clients who want a doctor get one. They even help us find them close to home if transportation is a concern. So connections were also made with the chiefs of both Kaitlin and Matsqui First Nations. And the friendship and communication continues to go both ways. So when they needed support, it was whether it was navigation, support for the local healthcare system, for sharing a frustration, or patient attachment, they could give us a call, and they still can give us a call. And when we needed an extra set of eyes, ears, or guidance on safe approaches or gaps and barriers to accessing care, we knew who to call. And then the team at Culturally Committed, which is led by Kim Trottier, provided our members with a safe circle to ask questions and receive guidance from elders and knowledge keepers. So this was a quarterly virtual circle gathering where questions or experiences from providers were submitted to the Culturally Committed team ahead of time to allow the circle of elders and knowledge keepers time to reflect and gather stories and experiences to share with our providers, where when we did gather, they would answer those questions in the group session and provide additional space to ask questions on whether it was how to practice with or deliver care, or a reflection on an experience with an Indigenous patient, or even more generalized questions of Indigenous history and how that may affect some of their well-being today. So as the project progressed and the circles with the leadership team continued, we heard that it was important to continue the journey with openness, to engage our partners from the beginning and not as an afterthought, to share visual representation in physical space, because this created a sense of welcomeness and respect, to approach patients in practice without judgment and stereotype, and to know that it is okay to ask about substance use, but maybe not start with it. Maybe start with a "how are you today?" instead of "how much alcohol do you consume?" And that there's a place for both traditional and Western medicine. And it's okay to ask the patients about their preferences, that patients aren't just a PHN. There is a relationship that needs to be built and that is part of the foundation of trust. Family matters, and that there are times where patients will want family, whether that's friends, neighbors, aunties, elders, to join them in their appointment. And that's because they may better understand or be able to listen to the medical or clinical terminologies being used, and that they would be able to share it with others who may be supporting that patient get to the next step of their care. And then on the side here, we have a couple more patient quotes that patients and partners shared when asked about their experiences after the completion of this project. So we knew we couldn't survey, or not survey, but collect data. So we were more focused on qualitative pieces, sorry. So one was that I walked into my doctor's office and saw Métis artwork, and that it made me smile. We trust the Langley doctors. They come to us and help us with flu shots. So part of our relationship with Kaitlin First Nations is that we do hold an annual flu and COVID immunization clinic for them at their clinic, so that patients do not have to leave the reserve and are comfortable in their own space. And then we asked the Langley Division for help, and we get it. There is a trust built from their approach and willingness to learn from our people. So a little bit of a visual break for you. Because of COVID, or because of the COVID aftermath, there were limited in-person events. But in some of these pictures are representations of ways in which we were able to engage with community. So a community-wide wellness event where we hosted representation from local organizations serving Indigenous populations were gathered and shared. And they shared information on initiatives and programs that were accessible and barrier-free. We were joined by Elder Poitras, who opened the evening in a good way and shared a lesson on the medicine wheel and provided smudging for those who wanted it. A good meal was shared so that all guests went home with a full belly. And our relationships continued to strengthen while the barriers to care were decreased. The learning didn't stop with division members. You can see a picture of our office team who are all engaged in the learning, wearing our orange shirts. And then there's a photo of Rain Pierre's Light of Irene. These prints were graciously provided by Doctors of BC, and we framed them and delivered them to all of our practices so that local art was recognizable in the waiting room of practices across Langley. And then Every Child Matters lanyards, orange t-shirts were gifted at member events and meetings to those who wanted them as an additional visual representation of our physicians' commitment to culturally safe care. Okay, so this is another print that was gifted to our practices. It is designed by local Métis artist and knowledge keeper Lisa Shepherd. You'll see a little bit more from her later. This piece was chosen because of what it represents, and it was felt that it was that it appropriately represented what we were trying to achieve through this project. So why so much visual representation? Because when listening to those at our leadership table and in the community, it was shared early on from one of our members that it was while visiting a local fair exhibit that one of the community members noticed welcome was listed in all languages but his own. And he shared how much this hurt and how meaningful it is to see visual representation in a space, and how much it can help with anxiety and nerves just to feel that little piece of comfort. So as we moved forward with our journey, it has also inspired the idea for some of our next steps, which include a territorial acknowledgement and our welcome sign, including the downriver dialect of Halkamelem, just to give acknowledgement to the land that our practices are on and to add that little extra piece of comfort into our practices. Okay. So move a bit more into how our physicians were engaged. So number of educational sessions were held. Again, a lot being virtual because of the timing. I won't read them all off to you, but highlight a couple. Open to feedback was one of our first educational sessions after Jody's session, and that was hosted by one of our local psychiatrists. And it was really to set the stage and support our members' minds to be open to the opportunity for feedback and how to receive feedback. So this kind of set the platform for the rest of the project. Yes was not mandatory, but all those who had not taken it previously, and I think it is now part of our residency program, those who had not taken it were offered to have the registration costs covered upon completion of the course. Bulletins, we have a weekly bulletin, and collateral were shared, and when appropriate, if a learning opportunity was presented, it was taken. We've got a bit of that shown on the next slide for you. Commitment cards were distributed at every event so that members could reflect and share or take their cards home as a reminder of their journey. And then lastly, some webinars, like we see in Two Worlds, were offered in group settings over a meal to give providers the opportunity to discuss learnings and outcomes in the moment. Some of the topics shared can be quite heavy, and it was suggested that these would be better received with the support of their peers in the room. So here are some of the pieces of collateral and learning materials that were shared with members either at events or through bulletins. In the blue is an example of one of the commitment cards. This template was shared by Jody. The Your Voice Matters card was shared with patients who identify as Indigenous. We had cards made as well as posters, but felt that the cards provided a little bit more of an opportunity to take home with them so that they could be filled out, so that the surveys or feedback could be filled out in a more comfortable space. And this was part of our feedback mechanism where patients had the opportunity to provide positive or negative feedback for physicians and the care that they had received and whether or not it was culturally safe. And those answers would be submitted to an online platform where I was able to review them and share it back with the providers to help correct or provide further education in those pieces. To be in good health. So at several events, we had Indigenous medicinal teas available, and with them came this card describing the ingredients and the intended traditional use. Again, taking advantage of every opportunity to learn. We also shared an open invitation to all of our events, to the leadership team and our community partners. So to be prepared, we carried a little engagement box with us. I don't know if it will show on screen. And in this box is thank you cards, gift cards, gas cards, tea, and some swag, so that no Indigenous guest had to wait for compensation for their time. And because we know checks can sometimes not be favorable, we felt that gift cards were an easier way to distribute compensation. And then the gas cards were given so that nobody would be put out for transportation. We also carried, for reference, one of our compensation guides. During the time of this project, one of the only ones available to us was through FHA. So we use that as a guideline or a base for what monetary value we would compensate Indigenous voices with. And then some of the other pieces here were just bulletin announcements, celebrations, and learning opportunities. So I've spoken a bit about the lessons learned as we progressed through the project, because some of these learnings guided us to the next steps or how to proceed in a bit more of an appropriate way. But here are some more impactful lessons that I have been told really supported the relationship building and the trust that our Indigenous community members have in the division office. So when engaging with community or with Indigenous community members, patients, and partners, it's important to be open. I've heard from someone before, maybe it was Gracie, that we have 2 ears and 1 mouth for a reason. Be respectful of their land, of their time, their knowledge and lived experiences. They are experts and should be treated with respect and compensated just like you would compensate any other expert in an area or specialty for their knowledge and lessons. Collaboration starts from the beginning. Engaging Indigenous voices at the end of a project to making sure that it's okay is not collaborative. That's a consultation. As above, it's important to compensate. Please feed and compensate time and knowledge as you would any other guest expert. Compensate fairly. There are guidelines, but don't be afraid to go above and beyond when you feel it is appropriate. Have funds available at the time of participation. Some elders don't have westernized checking accounts, photo deposit, or transportation to the bank. So make it as barrier-free as possible. Give more than you take. Simple as that. Listen actively and intentionally. Put down your pens, close your laptop, and really listen to what's being shared. There's a lot to learn from your leadership teams and your patient stories. Leave the colonial agenda and checklist behind. An important reminder that safe space to one may not be the same for another. That the pan-Indigenous lens does not suit all. But when you are taking the time to learn a little bit more about your patients and their families, you will recognize what is safe for them. One more that I was reminded of last night at a gathering with another group of community members and elders is that it's okay to be vulnerable and to ask questions, to make mistakes. I did, I have, I continue to, but I'm also encouraged to ask the questions that make conversations more comfortable. Example, on one of my first conversations with Chief McKay, I was both nervous and excited to be able to learn from her. But when she asked if I had a hard time finding the cultural center, I quickly replied, no, it's just around the corner. This is my backyard. And as it was spilling out of my mouth, I could feel my face turn red, and I started to apologize profusely. But she reassured me, or I was reassured, that I was in a safe space because Chief McKay laughed and said, it's okay. It's our backyard. And I'm glad you have fond memories here. And it was probably that same day that I learned that I could ask Chief McKay anything, and she would support me in any answers or guidance needed to move forward with our Indigenous community members. Nope. Nope. Okay. Okay, so here's Lisa Shepherd again in the background. Sorry. This is one of our physician engagement events. It was art as medicine, and Lisa led us through Métis art and how it evolved over the relocations and journey from Central to Western Canada. And in between the lessons were surprise brain breaks where she engaged our physicians and taught them how to jig. So we were able to get our shy docs grooving to the Red River Métis jig. As we wrapped up the project, of course, there was some evaluation that was needed to be completed to appease our funders. But due to the nature of the project, we were focused more on the qualitative and not the quantitative measures. So here are a few of the statements from our primary care members. One of the most impactful being that, and one of my favorite is that the experiences and lessons learned from meetings and education sessions have not only bettered my care for Indigenous patients, but all my patients. Okay, one last slide. So what have we done since the completion of this project? Well, I've had my arm twisted a couple of times to share our journey and story with other physician groups and shared care groups. We continue to offer and share educational sessions and opportunities hosted not only by the division, but by Doctors of BC, UBC, Shared Care, the JCC, and really any opportunities that we become aware of in our community that we see fit for our physicians. And with the support of our primary care network funding, we've been allocated 3 Indigenous specific FTEs. And with this, we are building an enhanced network of care to support the blending of traditional and Western medicine through a nurse, a social worker, and an FTE contract to be able to engage and compensate elders, knowledge keepers, and wellness keepers for services when Indigenous patients would like to blend the traditional and Western. We will be able to compensate them for their time, because none of our patients will have to be out of pocket for these services. Indigenous patients also have access to all of our PCN services. These will just be specific to Indigenous patients. Our relationships with our partners and community members continue to grow. We continue to take the extra steps in attaching Indigenous patients to accessible longitudinal primary care when they ask. We've just found that it is important to secure that attachment when a patient voices their openness to Western medicine or to seeing a family doctor, because we know it can be a scary or anxious time for them. Members have stepped forward and led their own smaller initiatives funded through other grants available to physicians. One example being our Meaningful Meals, which is a physician-led casual dinner opportunity with self-identifying patients or community members. And it just breaks down some of the barriers of who's who. Doctors aren't all that scary. They are people too. They get to meet them out of their scrubs or formal practice wear and have a good meal together. And one of the first ones was building a meal on a budget. So they got to make dinner together and learn how using limited resources can build a healthy meal, and then got to take home the ingredients to make that same meal with their family. And then we have 2 more coming up, but there are more projects and opportunities for change on the horizon, and the ideas or actionable items that present in every conversation with our leadership team or our community engagement pieces, or when we're working with our members, we just are trying to finalize those with the board and our leadership team to decide what's next. And I think to end it off, I forget where I first heard it, but care will only be safe when we are told it is. And until then, we will continue to work towards this goal in collaboration with our Indigenous community and their voices. With that, I think Sarah or Dr. Morrow will bring us back for some questions.
Thank you so much, Kaitlin. That was fantastic. Actually, I'm going to ask Gracie Kelly to come on camera, and I think Gracie has a few words to share.
A Quilt, A is for good, Quilt is for evening. Just want to hold my hands up to Kaitlin Frost and the Langley Division of Family Practice team who made this commitment and desire to continue the hard work and create their own meaning and definitions of what great collaboration means. I feel and share often for a long, long time that we need to always share our successes. And we learn from those successes, but of course, there are times where there may be some challenging discussions and or movement may not be as fast as we would like it to be. But from my witness tonight in the sharing that Kaitlin offered, that she and her team has this dedication to continue and grow and become that sharing work of supporting Indigenous within the Langley Division. You know, going back to some of the learning objectives, providing that Indigenous voice to help guide change for the partners in care who are also providing the supports. And it really is upheld, and much gratitude to all the discussions and mentorship she has had, as she mentioned, Chief Alice and, you know, the other First Nations communities that surround her. And that really continues to develop over time, and it becomes a lifelong learning relationship. And that's the desire that we all will need and grow from. So thank you for the work you're doing, and we'll continue our Q&A. Thank you.
Thank you for that, Gracie. Yes, I have to say, Kaitlin, you did a wonderful job presenting, very thoughtfully. You put a lot of work into that, and it was done so well and so clearly. And I'm just going to throw it out there that I think the word project is an understatement. What a comprehensive approach and effort you guys made. You know, you committed, you attached patients, you thought about the environment, you listened, you were responsive, you got feedback. It's quite an incredible feat. And we're going to move to questions now and maybe learn a little bit more. So we're going to go to Q&A for the remainder of the time. And as a reminder, we're using slido.com. So if you go to slido.com and put in the code Safe Spaces, we can ask questions. And I've got some questions ready to go. So we're going to have Dr. Van Schagen come back on screen as well. And I'm just wondering, Gracie, I don't think we asked you this, and I don't want you to put you on the spot, but if you hear a question and you think you might want to say something about it, you're certainly welcome to chime in as well. And I'm going to go ahead and start with the first question. So we have a question that says, what is the Indigenous viewpoint of meet and greet appointments with family physicians? Having recently moved to work here, I'm concerned this process of choosing patients may disadvantage Indigenous communities and would like to explore their view on this.
I can't speak for them on this, but from what we've heard in the experience, taking down the barriers of filling out pages of history and information that they may not have or know is one step to easing that barrier and access. I haven't heard any negative feedback from meet and greets. I also haven't had any feedback that meet and greets haven't been successful in attaching the patients to the care provider. Those providers that have stepped forward to be a part of our list are all very passionate and more committed to the cultural safety pieces of primary care. So they have gone above and beyond and out of their way to make it as comfortable for these patients accessing primary care.
Thank you for that, Kaitlin. And we have a response to the question online as well. And it says, as an Indigenous person, I personally like a meet and greet. Formal instructions are important for most Indigenous peoples, especially with our elders. So that was nice. Go ahead.
I'll just add that, you know, the division did prioritize. We had certain groups that we prioritized, and this was a priority population. So before the healthcare registry was designed, we were sort of matching our Indigenous people who wanted a family doctor. And one thing we learned loud and clear from all of the discussions we had with all of our Indigenous partners in this work was just ask us. We're open to being asked a question like that. How do you feel about a meet and greet? Or how does that fall? So, you know, we do ask what they would appreciate. So, but we did definitely do a matching process that was above and beyond the healthcare registry that now exists for the whole province. So,
Yeah, which is a fantastic thing. We're ready to move to the next question. Ready to go? Okay, so I love this one. I have worked in primary care for over 2 years now, and we constantly struggle with discharge planning for our Indigenous community members in the acute care setting. What have other communities done to improve relationships with acute care settings to better support our Indigenous communities?
To us, the acute care setting, well, we're lucky in Langley that we still have 26 family physicians still rounding on their patients in our hospital. So that longitudinal care or that care post-discharge is continued from the hospital. We are still trying to work with the health authority and the hospital on better and appropriate care. But we wanted to focus first on primary care, community care, and get that first piece of preventative care more safe for them. And through our PCN or primary care network, we are able to do more partnership with the hospital, with acute care, and do have some discharge programs that are being launched that will help support that care as well. We do know that 90, I think the last time we were able to do a data poll or just an ask of Kaitlin First Nations, which is one of our larger populations in Langley, 94% of those living on reserve who want to be attached to a family doctor are attached to a family doctor. So there is that community care available for them after discharge.
Great.
I'm sorry, we're still learning, so I should have said, by the way, I'm Dr. Carolyn Van Schagen, and I was division chair at the time of this project. And I acknowledge that I live and work on the sacred and ancestral traditional territories of the Matsqui, Katzie, and Kaitlin First Nations, and I'm very privileged to be part of this work. I am a second-generation Dutch settler, and I was raised in a very traditional background with a lot of respect for various institutions that we now see as normal in Canada. And so part of my learning has definitely been that not everyone approaches healthcare in the safe way that I have always approached healthcare, thinking that it's a safe space. And that's been a big learning for me. And my daughter, who's, you know, now just finishing university, she's like, oh, Mom, that's like 101. Like, yeah, I'm sort of in kindergarten of this work. And I'm so grateful for this project, as you said, maybe not even a project, but for Jody Jones and the wonderful learning. And she gave us a whole history of the background of what medical care has been like that day, that first group session that we had by Zoom. And that was such a wonderful, difficult, but excellent learning experience. So, so that's how we all became committed to this work. And I have to say that really without the division, like when you're talking about the hospital and the division and the health authority, Sometimes we're all the same, right? The province of British Columbia, the division, and sometimes we're all a bit different, but we have to make it clear that we all want to work together to improve health for all Indigenous members. So I think that became an important part. It wasn't an us against them, but this work would not have happened without the division and without the executive director sort of saying, this is important. This is going to be how we approach all of our projects, and having this very open door policy. And I think that is very important to realize that without that, it would be impossible to reach all the community family practitioners. So it helps at the hospital too, because we liaisoned with the community nurse at Kaitlin on reserve. We liaison with, now we will hopefully have a nurse in the hospital to help with discharge policies. That's part of what our PCN is actually doing. And then hopefully the Indigenous knowledge keepers that they're hoping to also have in the PCN will help with that work as well. So that will be part of our focus too. So just to sort of link all why I chose this question to answer that way. So
Thank you for that, Carolyn. That's wonderful. And it just underscores, I believe it sounds like the taking the time to build the relationships is bearing fruit in that example. We have some responses to that question online too. I'm loving this interactive component. Somebody says, I'm an Indigenous patient navigator with Island Health, and asking if they have a community nurse is usually a good start to engage the participation from each community and gain a better collaboration for future discharge planning. And also, I've been informed by many elders to connect with the community members rather than the staff. The community members will know who to trust and who to contact when they need the support. I hand my business card and brochures out like there's no tomorrow. There you go. Okay, we have another question now. I'm not sure if we can answer this one, if anybody wants to take it, but it might be a different topic. So good evening. Can anyone speak to the intersection between cultural safety for, oops, it looks like it was, oh, there it is. Cultural safety for Indigenous folks and cultural safety for Two-Spirit/gender diverse folks, or can a webinar be organized for this? I've not yet been able to find a cultural safety session that speaks to this intersectionality. So the intersectionality of being Indigenous and also being gender diverse or two-spirited.
We actually had Len Pierre speak to that. So Len Pierre and Len Pierre Consulting from Kaitlin First Nations does do a webinar learning series on that topic.
Excellent. Maybe we'll make a note to put that in somewhere for people to have reference to. It was a good answer. You had it.
Yeah.
Nice job. Okay.
I think it just comes with, we do also do a lot of work with Foundry and gender diverse. So it was only, I guess, natural from our point of view that we include that in some of our training and education pieces.
Excellent. I see that it's now posted in Slido. I'm not sure if that's the same course, but there's also a course from Transcare BC that is reportedly quite good. So that's the link to that is in the Slido as a response. Okay, in addition to having artwork in clinic spaces, can you share some of the other practices that patients identified as being impactful in helping them feel safe?
Yeah, it was, I think I mentioned not making any MHSU, mental health or substance use problems your first question, really asking how the patient is or how was their day, and starting off with good conversation before jumping into clinical questions. Listening to what they have to say really does answer some of your clinical questions without having to get into that Western colonial medicine piece of it. And it's going to differ patient to patient. But you really, what we learned was the physicians need to take the time to learn who their patient is. And they will share how it is most safe for them.
Thank you for that. And I've also learned that sharing something as the clinician, sharing something of yourself, especially when you're on and how long, or something about you, is goes a long way in Indigenous culture to, so to speak, have that handshake and then open a conversation. So it's a nice start to a visit to share something about yourself as well. Okay.
Is it
Go
okay
ahead.
if I just add?
Absolutely.
One of our talks, I believe it was Jody Jones as well. She did a medicine wheel presentation and some traditional medicines, and most of the indigenous partnerships that were there said it is good to have visual things, like maybe tobacco plant in clinic, or just so that they know you're open to at least discussing some other approaches. And that is a very visual way to just say, hey, you can ask me about this, or let me know if you're using some traditional practices, or just having the medicine wheel visualized. And I just want to put a plug out for involving whoever your MOAs or booking people or unit clerks are. I've seen a lot of good work undone by a harried unit clerk who didn't understand. They just don't have the same information maybe. So I think it is important to involve all the staff surrounding the team. I mean, medicine's a team approach now, right? So the whole team needs to be educated, because I've seen people get in trouble for showing up late because the bus was late, and being turned away because, our MOAs are really good at protecting us. They really want to take good care of us. So trying to work out solutions of maybe they're going to book the last appointment before lunch. I really love the new model of billing, that now we can spend the time, right, and make room for that extra time if needed. And I do believe that, because we don't all come from an equal setting, some people do need extra time. That's all there is to it. And to build relationship and to work with someone who feels unsafe, I think you do need extra time. So just working with staff to make that time too.
Terrific point. Thank you. Next question. How were you able to attach all Indigenous patients that wanted to be? That's terrific. That's what it says.
You want to take that one?
Sorry, I was distracted. There was just a comment or a question about if an Indigenous person was a part of this project. So yes, our leadership team was made of 12 at most, depended on the day, local Indigenous community members, and that varied from on reserve to urban Indigenous away from home. We had elders and chiefs involved in that table. Unfortunately, due to the timing of the presentation and celebrations of their own this month, some of those leaders were not able to join us tonight, but they were asked, and there was an open invitation for them. And sorry, Dr. Morrow, can you repeat the question?
Yeah, it's Chris, by the way, but yeah. So how were you able to attach all Indigenous patients that wanted to be? That is terrific. That's what it says.
We have a terrific membership. We have over 150 through, I think we're close to 155 practicing physicians now in Langley. And I have my secret list of 15 to 20 physicians who have given me the okay to contact them directly when a patient does need attaching, and they make space in their practice for that patient.
That's fantastic. That's a great story.
I should say we work with a lot of nurse practitioners and primary care providers as well.
Nurse practitioners, yeah.
We have great teams in Langley, so we're very lucky.
That's are the nurse practitioners on that secret list too?
Yes.
Yeah.
Yes.
Okay. So here's a question. Is anybody else conducting community-based two-eyed seeing participatory research in Indigenous communities in BC. My area in particular, a DSC student on healthcare musculoskeletal equality for rural, remote Indigenous communities on Western Vancouver Island. Thank you for offering this webinar. So anybody else conducting community-based two-eyed seeing research in Indigenous communities in BC that anybody's aware of? Carolyn, Kaitlin?
Not that I am aware of or honestly have looked into. It hasn't come up as a need or in any of our discussions yet to look into it further for our community specifically.
Okay, great. And then Anonymous replied, I'm intrigued as well and hope to hear more too. I am engaging in research with the Shwempik Nation, and they refer to it as walking on two legs. Keen to learn more. Thanks for putting this question out there. We have a question for everybody to think about. Next one, social determinants of health informatic measures tend to be more deficit-based rather than strength-based. Do you have any experience or guidance on how to move forward in exploring social determinants of health in a strength-based way that is more culturally safe, while also ensuring we address issues impacting access? That's a tough one.
Well, naturally, of course, the majority of gaps and barriers come up as a deficit. But if I reflect on what Gracie was saying and the positivity of moving forward and getting those education and awareness pieces and just working in a good way with your community members, those positive changes or the amplification of projects through positive pieces will soon come naturally.
Right. So focusing on strength, I like that theory and that outlook. Another question, does Western medicine and Western psychology colonize Indigenous clients by dismissing the credibility or legitimacy of their own Indigenous healing practices? Should evidence-based treatments be privileged regardless of cultural context? And should non-science cultural healing practices be publicly funded? So, a few questions there. Philosophy about our approach to Indigenous care.
I can only speak to what we've heard as feedback, but I think part of this journey that we've experienced was creating or taking down the barriers and stereotypes and really opening up our physicians, our care providers, our nurse practitioners, and any specialists who were participating in our education pieces to move forward with open minds and with the education and history or stories that we were sharing with them, that those were part of the lessons learned, and being able to be or coaching them more towards that openness, that open-heartedness, that the open ears is part of being open to the traditional wellness practices and how can they be blended with Western practices if that's what the patient wants. I think from what we've heard, when patients are looking for a longitudinal family doctor, it's because they are a little more open to the Westernized or science medicine, but our physicians are open to blending that with the traditional if that's what the patient is asking for. And we are lucky to have these PCN resources coming in to help support that as well, and build that traditional wellness access and navigational supports for our patients.
Thank you, Kaitlin. Great job. great answer. How has this project affected the involved physicians' enjoyment of their work?
Carolyn.
I think the education component has been quite eye-opening for a lot of our physicians. And I love the quote that Kaitlin put up. Like lots of education, it becomes applicable to other areas of medicine and assisting other patients who are dealing with trauma or other barriers to health. And I think our membership has really experienced that even if they have not had a large Indigenous or identified Métis in their practice, I think they all feel that their approach has been improved, and that makes things easier. I suppose easier might not be the right word, but I think they feel like they can assist more. And I think that having the PCN open up and having resources as well that they know about now, where, you know, the movement to team-based care, and that, you know, one person isn't going to fix all of this, you know, or that we need help with that and reaching out for that help. I think that's also very important. And just on the previous question, I think we were trying to create a safe space. We were trying to get engagement both from physicians, but also from the Indigenous community. And I think that went well. I think it's really next steps to really look at, okay, and I think Kaitlin's quite right. We didn't hear from our Indigenous participants that they didn't want Western care. Don't get me wrong about that, Western care. They want a little bit of both for the most part, and just support to be open to at least hearing about what other things they're doing. So, or that would help them in their journey to get to better health. So,
Carolyn, that was your quote.
It's good I forget what I say.
Yeah.
I'm gonna combine a couple of quick snappers. Are the visual resources available to those of us who are not part of the Langley community? And how do I get some of those cards that invite Indigenous patients to give feedback on their interactions with me?
So Light of Irene, I haven't checked recently, but I believe is still available through Doctors of BC. The work of Lisa Shepherd is available on her website. The cards for the feedback mechanism were created in partnership with some of our local community members, just to make sure the wording and approach was correct. It is a link that goes to me. So I don't know that you want to be giving those cards out in your community, because I don't know how to reach your physicians, but I'm happy to share the behind the scenes platform, or a snapshot of the platform, if somebody wanted to work with their community to make sure it was safe for their community as well.
Yeah, we definitely heard loud and clear that our Indigenous partners wanted to hear their language. They wanted to see their language. And so she showed you the card, but she actually made quite a wonderful poster with, I think it was the word welcome throughout in many, many different languages of our local communities. So, because we heard loud and clear, language was very important at our tables. So.
Great. Okay, we're doing great. Next question. We are an Indigenous primary care center that has 2 primary care RNs and 3 NPs. All our clients are Indigenous. We've had struggles with community members being discharged from the hospital without support set up because they don't know who we are, despite multiple conversations with staff. How can we change this?
I would reach out to your division. Your local division should have that connection with their hospital to be able to help advocate for those resources. If the health authority piece and the hospital are not taking that in, then at least the division would be able to reach out more on the community level and will most likely have a better relationship with patients, providers, and the Indigenous community members.
Yeah,
Thank you.
We, for all of our projects, if it involves the hospital, you go multiple times and you leave cards and you leave posters and they do reminders, not just for Indigenous work, but for any of the changes the division tries to make in conjunction with the hospital. So yeah, it's difficult. I hope that you keep trying and leave visual reminders. That's what Kaitlin's always dropping little things off so that people see it, touch it, feel it, and it's hanging on the wall, that kind of thing. I'm sure you've already tried all that, but anyway, we just keep going.
Yeah, the hospitals are unique places because they're so variable, and it takes a long time for anything to stick. And then once it's stuck, it takes a long time to unstick it as well. I've noticed that. I've got another question here where there's been a reply, which is really great, and I'll read the reply first and then see if you have anything to add. So I work in a small community hospital with Island Health. How can I bring a similar collaboration to our community? So great to hear this question. And Anonymous responds, does your faculty have a medical staff association? MSAs can use facility engagement funding from the shared SSC to support physician-led QI and community-based initiatives. You can actually research the Facility Engagement Project database for ideas and contacts, and then they've given a link. So that's one way, through the MSCA.
The connection, to help with the connection between the community and you could do a project, yeah.
Yeah, MSA divisions, again, I think divisions have more of that capacity to help support those relationships.
Okay, great. And I believe there's multiple divisions on Vancouver Island. I think there's 8 or something. Do you have ongoing learning opportunities for staff to continue their education? What model do you use? Monthly, every 3 months, something different? And is participation mandatory?
First, participation is never mandatory. We do respect our members' times and schedules. They are busy with their patients and their families. And we do not want to force learning on anyone who is not open to it. As for schedule, again, capacity of our physicians, capacity of our staff at the division, and not to overwhelm with other sessions being offered, because we do know that there are lots through Doctors of BC, JCC, the college, the health authorities. So we don't want to create a burnout either. So it's an as needed, and it continues to be offered when appropriate, or when our board or a member comes forward with a need for a certain education topic surrounding patient care or cultural care.
Great, thank you. I think we're going to end it there. That's our time for question and answers. We got to almost all of them. We'd probably love to continue talking all evening, but I think we've asked a lot of you, Kaitlin, and you are a trooper. You did just an amazing job. So I'd like to really express my sincere gratitude to both Kaitlin Frost and Dr. Van Schagen for this webinar, and thank you all for taking time out of your busy lives to be here. And we're sure that this was a good experience. I also want to acknowledge the hardworking UBC CPD staff, without whom the delivery of these webinars would not be possible. And thanks, everyone, and have a great night.